So, after a brief pause, we have again come back. So, today it is a thyroid function test and the entire story of thyroid. So, it's a very common thing, and everybody is well aware of it that thyroid hormone takes a huge role in our day to day life. And so, first start with the thyroid hormones. The thyroid tail is the long and short of it. So, the first giving a brief idea about the thyroid gland, how it looks like. Is just look, it is placed in front of your hyoid bone, beneath the hyoid bone, and this is the too low one which has connected in between with an isthmus, supplied by superior thyroid artery and inferior thyroid artery and the veins. So very complex and a very vascular structure. So this is where thyroid hormones are produced, and this gland is one of the major endocrine gland of our body, which is called thyroid hormone, thyroid gland. So now what about go for a thyroid hormone family? So I ask anybody, name the 3 thyroid hormones. What the answer, The answer T3, T4 and TSH, which is wrong. A thyroid hormone means there are 3 thyroid hormones which secretes from the thyroid gland itself. They are T3 or triiodothyronine, T4 or tetraiodothyronine, and the last one is thyrocalcitonin. The first 2 are secreted from the follicular cells of the thyroid gland, and the third one, thyrocalcitonin, it comes from the parafollicular C cell of the thyroid. But thyrocalcitonin is not considered one of the thyroid hormone because it plays its major part in the calcium metabolism. But other 2, T3 and T4, are mostly known as the thyroid hormones. So since this is a very complex thing, how it is synthesis and release happens. First of all, inside the thyroid, the iodine concentration is much higher than outside. So if you want to uptake, first it is uptake from blood. Thyroid gland takes some the iodine for its use, and this uptake is an energy driven because it is against the concentration. Inside the thyroid gland, the iodine concentration is much higher than blood. So it is taken inside with the process, which is an energy driven process. So with the sodium channel. After that, this iodine, this is a rate limiting step, the most important stage. Iodine converts to iodonium by oxidation. This oxidation is done by the enzyme thyroid peroxidase. So this thyroid peroxidase enzyme is actually the rate limiting step of the entire thyroid hormones formation. Once it forms the iodonium, there's another formation things happens. So there is one amino acid, which is essential amino acid called tyrosine. So the tyrosine is used for thyroid hormone synthesis. What happens after this iodonium ion is formed? It causes iodinization of the tyrosine and produces monoiodotyrosine if one iodine is attached to it, or it becomes diiodotyrosine or DIT when it is attached with 2 iodines. Now this is after the oxidation. The next step is called coupling. When one MIT joins with one DIT, it forms T3. Tetra is triiodothyronine. But if one diiodotyrosine couples with another diiodotyrosine, it becomes tetraiodothyronine or T4. So out of them, T4 and T3 are taken up in the cell, and it cause an insight by force so that in the blood, the form of the hormones are available. So this is how, in a nutshell, very complex process, but I am giving a nutshell. But entire process of formation of thyroid gland, the rate limiting step is a thyroid peroxidase or the oxidation of iodine. So as I have already been given all the details, so I am not enhancing that. One thing is that this, what I told, that against the concentration it is coming through a symporter, sodium iodine symporter, and with one molecule called pen ring. So rest of the things I have already discussed in the process. So this is how it looks like. The chief hormones There is another hormone is here. So I said that one diarrhytyrosine and couples with another diarrhytyrosine to form 3 prime 5 prime tetrahydrothyronine. So these are the 4 areas where iodine is attached. Now there are 2 processes. In one case, it can have MIT with a DIT, where 3 prime and 5 triiodothyronine, this is T3. But instead, by chance it changes position and makes a 3 prime 5 prime one that becomes reverse T3. The reverse T3 is not an active hormone. So by chance, because of the position of iodine, our T3 can convert to reverse T3, but this reverse T3 is unable to produce any function of a thyroid gland. Now, thyroid hormones, you will always find there is concept, there's a T4, FT4 or something. Why it is so? Because you have to understand that among this entire hormone which is produced, only 1% are in the unbound form. That means thyroid hormones are not very water soluble. They are lipid soluble. So they need some carrier. So mostly it is carried by the 2 things. One, thyroid binding prealbumin. Another one is thyroid binding globulin. Sometimes albumin also becomes their carriage. So 99% of them are protein bound thyroid hormones, which is inactive. Only 1%, which is not protein bound, are active thyroid hormones. So metabolically active are only the free hormones which is not bound with the protein. Now, how it mechanism of action? It's a very critical one. I'm not going to go in detail, but what I can say that it does not act on the cytoplasmic area. It acts in the nucleus. So being a lipid soluble, it can get into the nucleus, and therefore it can act on change in protein synthesis of cellular response. So therefore, this is basically one of the like a steroid hormone like of mechanism of action, which is mostly nuclear mechanism of action. It goes in the nucleus, and therefore the entire protein and other formation that alters. Now, what are the actual functions of thyroid hormones? Actual function of thyroid hormones are the first and foremost thing, the basal metabolic rate. It helps to maintain the basal metabolic rate of your body. What is the basal metabolic rate? It is that the minimum activity with a basic lifestyle activity needs some metabolic rate to achieve the amount of ATP or energy. So thyroid helps to that produce that BMR in your body. Also helps in glucose metabolism, protein metabolism, cholesterol clearance, growth and sexual maturation, very important, the cardiovascular and respiratory functions, gastrointestinal function and hematopoietic function, all somehow thyroid hormones has got some action. But the principal action is maintenance of BMR. Now, how the thyroid hormones are kept in control. So thyroid hormones are produced by the thyroid glands, but it is actually remains in a concentration which is exactly required for your body. How it maintains? It maintains with a feedback mechanism. So thyroid hormone is being monitored and controlled by anterior pituitary through a hormone known as thyroid stimulating hormone or TSH. TSH, this anterior pituitary again, also being monitored and controlled by thyrotropin hormone or thyroid TSH releasing hormone or TRH. What happens if thyroid is releasing huge amount of T3 and T4? It creates a negative input towards the pituitary as well as the hypothalamus. Hypothalamus holds back TRH secretion. Therefore, TSH secretion is also held back, and push to produce more T3T4 is reduced. So therefore, thyroid can itself regulate its secretion. Sometimes the opposite happens. That means when the thyroid cannot act as per the requirement, so the less amount of T3 and T4 are there. Therefore, hypothalamus is sensing the less amount of thyroid hormones are secreting. So what it causes? It actually releases TRH, which at the same time, after getting the push from TRH, more and more TSH is released. Now, TSH plays the major role in production and release of thyroid hormones. So, excessive TSH can release more and more hormone and can actually gap the deficiency. So, therefore, this is a circular inhibitory and excitatory cycle which goes on. So, if it works high, they will counterly will work low so that the activity remain down. If it is activities are remaining down, then they will sense it and they will do more and more so that the deficiency is made up. This is how the homeostasis of thyroid hormone happens. It is a three-layered control system. The top system is hypothalamus, further controlled by anti-pituitary, and therefore the final action happens on thyroid hormone itself, thyroid gland itself. So regulation, as I told, it is an auto-regulation. Second, neuroendocrine regulation. Two types of there. So that rate of iodine uptake and incorporation into thyroglobulin is influenced by amount of iodide available. Therefore, if your food is having low iodide, so it will not be able to give you the raw material to produce the material. So, if there is a raw material deficiency, the production automatically will decrease. And that is why in the areas, particularly in the hilly areas, where iodine is not very easily available, not available in the food and other system, so therefore they are tend to have hypothyroidism. So that is why we have given Government of India as in an iodized salt to just replenish the iodine deficiencies. But there are other things where the neuroendocrine regulation of TSH, as I told you, via hypothalamus. So what is the role of TSH? TSH has got a major role in T3, T4 formation. The first and foremost, I told you, the rate limiting step. What is a rate limiting step? When there's a series of actions are happening, the slowest of the movement is called the rate limiting step. So, a slightest change in pace can do a huge difference in rate and time. So, that is why the TPO is the rate limiting step of thyroid hormone production. It enhances TPO action. Iodide transport into follicular cell is also helped by them. Production of thyroglobulin, that is very important, is also done by TSH. And endocytosis of colloid from lumen to follicular cells. And last but not the least, the T3 and T4 are formed. T3 is the active form. So, in the periphery, the T4 converts to T3 to perform the action. And this peripheral conversion is also held by TSH. Now, extrathyroidal factors that regulating thyroid hormones. What are they? High cholesterol diet increases T3 level. So, increased metabolic rate also. Drugs like lithium or amiodarone, they compete with thyroid hormones, so therefore hinders the thyroid hormone formation. Lithium does by iodine trapping and amiodarone by replacing thyroid hormone from its bound albumin. So they can reduce the activity of thyroid gland. Sometimes amiodarone by replacing bound to active to free form sometimes increases the activity as. Or any condition which prolong the increase of energy requirement. As you know, thyroid hormone's main principal function is to produce the basal metabolic rate or energy for the body. So when there is a excess energy requirement, like in pregnancy or in prolonged cold, it can increase the thyroid hormone secretion. So therefore, I'll come to this later on. This is some conditions which we'll come in later on. Let's see. So actions of thyroid hormones on TSH synthesis and release. What that is already I have told, which is called a positive feedback and a negative feedback. Like TRH or TSH releasing hormone or TSH, TRH or thyrotropin releasing hormone, they have a positive stimulation on TSH. Therefore, it pushes TSH to act more. TSH again has got a positive stimulation on thyroid hormone production. Again, the thyroid hormone concentration itself give a negative feedback to both TRH and TSH. So that actually helps to balance. That means if TRH is overactivated, TSH is also overactivated. So more and more thyroid hormones are produced. If the concentration of thyroid hormone is high in the blood, that actually inhibits both TRH and TSH. Therefore, the positive as well as the counterback negative feedback both actually help the thyroid hormones to stay in a normal level. Now, disorder of thyroid hormone due to thyroid hormone abnormalities, there may be some simple goiter, sometimes exophthalmic goiter. That these are the feature of hyperthyroidism. With see this eyes, they are like projecting eyes. This is called exophthalmos, or sometimes they're very unfortunate congenital hypothyroidism is a development, particularly brain development up to 5 years. Baby requires thyroid hormone very badly. So that is why whenever there is a deficiency at birth, there is a congenital hypothyroidism, which is very, very unfortunate for the baby. Now, thyroid disorders presenting with hyperfunction are three conditions: Graves' disease, thyroid storm, or toxic nodular goiter. So that I'll come all in detail later on. Thyroid presenting with hypofunction are cretinism, that is called with the neonates born with hypothyroidism; myxedema, that is acute condition of hypothyroidism; postpartum thyroiditis, subacute thyroiditis; Sick Euthyroid Syndrome or Hashimoto's thyroiditis. They sometimes present with hypofunction. Sometimes they are with hypofunction. Sometimes mimics hypofunction. Actually, it is not. Therefore, there are some general symptoms of overt hypothyroidism and hyperthyroidism. Very carefully, you look at it. Hypothyroidism and hyperthyroidism both have a common symptom. One is hair loss. But others, like goiter, reduced heart rate, lethargy, fatigue, dry skin, and very sensitive to cold, unnecessary weight gain despite of losing appetite, then irregular menstrual periods, particularly menorrhagia. That means either excessive bleeding or extended period of bleeding called menorrhagia. Premenstrual syndromes are very high. Depression, very common. And joint and muscle pains are also very common. Sometimes ankle jerks are also very much diminished. Just the opposite you may see in most of the cases. Bulging eyes, which is called exophthalmos. Sometimes goiter. Goiter in hypothyroidism is mostly smooth. Goiter in toxic nodular goiter are not smooth mostly. So they have a excess BMR production. In hypothyroidism, everything, because BMR production was low, energy was low. But this is just the opposite. So they have basically the opposite things like pounding heart, the severe tachycardia, which is in hypo, it is a bradycardia. Then hypo could not tolerate cold, but it is due to excessive BMR production. They are heat intolerant. They are having weight loss gradually despite of having excessive appetite. But they have a hypomenorrhea. That means irregular menstrual period with a small amount of blood or very small numbers, 1 or 2 days of total period. So they have a period disturbance, but the opposite. Excessive a BMR can sometimes lead to tremors. The person always having this tremor like this. Hypothyroid people are always sleepy, but rather a hyperthyroid having all sleep deprivation. In that case, they are in the depression. They are having more about anxiety and nervousness. So these other things are very just the opposite symptoms you might find. So one thing is common is hair loss. Another find sometimes is a goiter. Rest all are just the opposite. Signs and symptoms are found in thyroid disorders. So indication of screening for thyroid disease, when you will actually going for screening of a thyroid disease, when there is a family history, there is sometimes history of autoimmune disease. Some of the autoimmune disease are always associated with autoimmune thyroiditis. Now, neck radiation, sometimes you have a neck irradiation. So, radiation on neck sometimes destroys the thyroid hormone. Elderly woman more than 35 years, very much prone. First trimester of pregnancy. Why first trimester of pregnancy? Because we cannot afford to be the mother hypothyroid during her pregnancy, because the baby will suffer most. 6 weeks to 6 months postpartum, that is also because the baby is breastfed during that part. So that time also you cannot afford the mother to be hypothyroid. Sometimes if you are taking medications like lithium or amiodarone, you should always check, because they can lead you to hypothyroid. And all neonates, because that is the baby's brain development. Thyroid hormones T3 and T4 are very, very much reported. So in those cases, you should always check the neonates thyroid status, and if there is any deficiency, you must treat it, supplement the thyroid. Now, assessment of thyroid function. So, main is immunoassay. Now, immunoassay started with ELISA. So, ELISA nowadays, there is a problem is that ELISA, the lower level of detection is sometimes not up to the mark. So, that is why now it has enhanced with chemiluminescence so that it becomes more sensitive. Even a minute change of TSH can be detected. So, what happened? It helps you to treat the hyperthyroidism much better. Because in such conditions, when the TSH level is suppressed below 0.5 or something, in that case, ELISA may not read it. But in CLIA, you can read up to the lowermost point. So your treatment facilities are much better. So the immunoassay are actually two types. For TSH, we use sandwich ELISA or sandwich immunoassay. And for T3 and T4, we use competitive immunoassay. We'll come to the immunoassay topic later on. This is not the time. So what are the biochemical parameters mostly assayed in thyroid hormone function test? They are, first and foremost, most importantly, TSH, although it's a hormone of the anterior pituitary, but the most sensitive one for detecting thyroid problems. Thyroid stimulating hormone. Then free T3, free T4. Total T3 and total T4. Thyroglobulin, sometimes it is also required. Sometimes you want to know whether there is any autoimmune disorder or any thyroid disorder. So you have an anti-TPO and anti-TG. Anti-TPO means the antibody develops against thyroid peroxidase enzyme itself. And anti-TG when the antibody develops against the thyroglobulin. There's another one, anti-TSH receptor antibody. It's a very peculiar one, comes with a Graves' disease, where the antibody, instead of inhibiting, it promotes the function. So there are more and more TSH formation, and it actually helps like a TSH receptor and activates thyroid hormone to be produced more and more. Also, certain times, like in pregnancy and other cases, when you find a high T4 or T3, you may need to see that whether this is because of excess protein or not. So, in that case, thyroid binding free albumin or thyroid binding globulin, the principal two one that actually carries thyroid hormones in the blood can also be checked. So, these are in a nutshell are the parameters you need to assay. These are the biological reference intervals, as you can see, of all the molecules which you are assaying. So mostly, most important is this TSH. We'll talk later on. This is as a whole the algorithm, basic algorithm. First, you check TSH. After you find it a high TSH, measure FT4. If you're low TSH, measure FT4. Now, if FT4 is high, then you have to find it what it is a secondary hyperthyroidism, because there is no problem in the thyroid gland. It is a pituitary gland which is secreting more TSH, and therefore it is leading to high actions. If it is normal, then you have to think of a subclinical hyperthyroidism. What is that? That is a hormone. There is a problem in the thyroid hormone. We are overproducing this T3, T4. But what happens? That gives a negative feedback. TSH holds back. So you get a hypothyroidism. So if the function is less T3, T4 is coming out, they are giving a less negative feedback to TSH. So therefore, TSH is going more and more to produce that much of T4 which makes the patient euthyroid. So this is the condition called subclinical hypothyroidism. Similarly, the same opposite side called subclinical hyperthyroidism, where excess T3, T4 formation are restricted by low TSH or withdrawing TSH. But I will come to this in a separate chapter as a whole. Subclinical hypothyroidism, very, very important thing, that sometimes the hypothyroidism is happening, but excess TSH making the T3, T4 in the normal side. So patient clinically euthyroid, T3, T4 are within normal range, only TSH is high. So you may have to think of this subclinical hypothyroidism. That means the thyroid is not functioning well, but it is compensated by excess TSH formation and excess push of TSH. So this also called compensatory hypothyroidism. So there is another primary hypothyroidism when actually you will find a very low T4. That means despite of high TSH secretion, still they could not get adequate T4. So this is an algorithm. Go with it. It will help you to measure step by step what is happening what. Nowadays, FT4 is measured more preferred than T4. So the algorithm says T4 and FT4 and TSH are a better marker than others. Key points when you are talking about TSH must be whenever there is a baby is born, by 40 to 72 hours after birth, a heel puncture should be done and tested the TSH. TSH is a major problem. It has got a circadian rhythm. So usually it peaks its secretion between 2 to 4 a.m. and goes to nadir by 5 to 6 p.m. So never try to repeat a test when a morning sample of TSH is taken. Never do a night sample TSH to actually check whether your performance are okay or not. Because it fluctuates with the circadian rhythm. A morning TSH can never match with the evening TSH. So these are other things. When there are sometimes you may find an excessive total T4, that may be because of overt synthesis of TBPA, particularly happens in pregnancy. So for those, FT4 measurement is much preferred to get the actual. When there is a thyrotoxicosis, then in certain conditions, total T3 measurement is much better because total T3 is the main active hormone. So sometimes to get a thyroiditis, you should check the anti-thyroid hormones, particularly anti-TPO, anti-TG, or sometimes anti-TSH, particularly in Graves' disease. So biochemical techniques that is used for, as I already have said, first is ELISA and RIA, also enhanced chemiluminescence, and now the off-choice material. So other also there, agar-gel or heme aggregations are there. But nowadays, the thyroid hormones are mostly tested by chemiluminescence, and sometimes the latex particle agglutination or others are used for antibody detection. Now, thyroid disturbances of clinical significance. What are they? Clinical conditions can be hypothyroidism or hyperthyroidism, sometimes autoimmune thyroid disease, thyroid perturbations in pregnancy, thyroid neoplasia, and congenital hyperthyroidism. Let's have a quick look on it. What is hypothyroidism? That means the formation of T4 is lower than adequate, T3 is lower than adequate. So it is either maybe subclinical hypothyroidism or maybe overt hypothyroidism. In subclinical hypothyroidism, what we'll find, the T3, T4 are barely within normal range, but TSH is high. But sometimes even more push of TSH are unable to produce adequate T4, T3. In such case, you will find high TSH but low T3, T4. They are called overt hypothyroidism or non-compensated hypothyroidism. Now, sometimes you may find in T3, T4 TSH, you always may not find that T3, T4 is low and TSH is high. Sometimes you may also find a low T3, a low T4, and low TSH. Don't get confused. In such cases, this is called a central hypothyroidism. That means here the problem lies in central, either in hypothalamus or in anterior pituitary. So what happens? The TRH or TSH is not secreted adequately, which is leading to a final outcome where T4, T3 is not produced. So this kind of hypothyroidism is called central hypothyroidism or secondary hypothyroidism. Causes may be primary thyroid dysgenesis, Hashimoto thyroiditis, congenital birth defect, or very common, particularly Indian in subterrane and also in the hilly areas, iodine deficiency. Central may be a pituitary disease or hypothalamic disease, which can reduce secretion of TRH or TSH and finally can lead to a low T3, T4. But there are some transient conditions or subacute thyroiditis which may cause hypothyroidism. Now, hyperthyroidism is defined as sustained increase in thyroid hormone biosynthesis and secretion by thyroid. So, there may be Graves' disease or some autoimmune disease. What happens sometimes, as I told, a transient one, sometimes the thyroiditis happens, there is inflammation in the thyroid, so thyroid cells are burst. So the more and more thyroid hormones are coming in the blood, that can cause a transient hyperthyroidism that remains for 15-20 days, and after it heals, it may again go to normal. As I told you in this case, there's transient causes. Transient is a hyperthyroidism, which may later on can convert to hypothyroidism also or to normal. Now, in Graves' disease or autoimmune disease, there are excessive T3 or T4 formation and leading to all these cases where very low TSH, almost undetectable with excess T3, T4 formation. So this is called a hyperthyroidism. But if it goes too much, if there is an so excess that the patient is unable to lead his life, this is called thyrotoxicosis syndrome. That means there's a excessive formation of T3, T4 that can make your life almost bizarre. There are subclinical hyperthyroidism, of course, that is the thyroid nodule. Some of the thyroid nodules, they become hyperactive and sparks release T3, T4. To counter that, the negative feedback holds back TSH. So TSH goes to very low or below normal level, therefore making T3, T4 restricted towards normalcy. So this is a condition where there is hyperthyroidism, but countered by low TSH, so the person becomes clinically inthyroid. This is one called subclinical hyperthyroidism. What can be the causes? Graves' disease, hashitoxicosis, toxic nodular goiter, some gestational postpartum thyroiditis, struma ovary. Sometimes there is an ovarian overproduction of TSH. Exogenous or iodine-induced hyperthyroidism are also seen, and obviously infection in the thyroid leading to thyroiditis. There are two kinds of autoimmune thyroiditis, I can say. One is Hashimoto's thyroiditis, another is a Graves' disease. One is a T-cell mediated inflammation of thyroid tissue, may be associated with other autoimmune disorders, characterized by goiter, particularly in case of Hashimoto's, or atrophy in case of atopic thyroiditis. Hashimoto is the most common cause of goiter and hypothyroidism in totality. Particularly the iron deficiency area, it is more commonly seen. So how you diagnose those antithyroid disorders? When you find the antibodies against it. Mostly anti-TPO in 90% cases, anti-TG in 20 to 50% cases, and sometimes there may be anti-TSH antibodies also. In pregnancy, what happens? Both hypo and hyperfunction is possible. Most common is subclinical hypothyroidism. So that is very, very dangerous because that can affect the neonate, the brain development and other organ development of neonates. So therefore, is the last thing we could tolerate for it. So, therefore, is a very important thing. The gestational hyperthyroidism usually subclinical, sometimes Graves' disease also precipitate in case of pregnancy. As you know, thyroid receptor stimulating antibody, particularly in Graves' disease and postpartum thyroiditis, are very common, and therefore you be aware of whenever the pregnancy leads to a hyperthyroidism, you should check the autoimmune status as well. There are thyroid neoplasias, that means cancers, can be papillary, can be follicular, can be medullary carcinoma, can be anaplastic also. Calcitonin is secreted by parafollicular C cells, which is the chief biomarker of medullary thyroid carcinoma or MTC. Vital to monitor TSH suppression therapy and for cancer ablation and detection of recurrence. Thyroglobulin is very useful marker for disease recurrence because it should be undetectable of thyroidectomy. If even after thyroidectomy, if you are finding thyroglobulin in your blood, there may be a chance of recurrence of the thyroid neoplasia. Now, role of calcitonin in medullary thyroid carcinoma is secreted from parafollicular C cells and from MTCs. So, this is used for screening and evaluating disease progression. So, fasting sample is preferred and it is very highly degraded material, so it has to be transported in ice. And chemiluminescence is the preferred mode of calcitonin. Yes. Then we come to congenital hypothyroidism, a very, very unfortunate thing. When the baby born with hypothyroidism. So that ranges 1 in 2000 to 1 in 4000 light bulbs. So therefore, nowadays, a TSH screening has become very, very essential because as I told previously also, it is around 5 years that TSH is T3T4 is required for development of brain of the babies. And if there is any deficiency, that can lead incurable thing after 5 years. So, this congenital hypothyroidism is categorized either as a permanent or transient, as sometimes primary or central. Central means the problem lies in the pituitary, primary means the problem lies in the thyroid. Transient time is most common due to inadequate maternal iodine. That's why I am saying maternal iodine is the most important to supplement. And checking mother's condition, thyroid status is very, very, very essential. So, clinical condition variable, the levothyroxine should be given as early as possible to avoid mental retardation. So, therefore, early age newborn screening with TSH is a very, very priority, sometimes with T4 and thyroglobulin as well. These are the clinical features of congenital hypothyroidism. These are growth failure, mental retardation, flat back of head, abnormal ears, many loops of finger tips and all this, umbilical hernia, abnormal pelvis and so on. So this is a very unfortunate thing when a baby is born with this kind of a thing, which is totally preventable and curable. So if it is so, has to be treated first. Key points in diagnosis. Second to fifth day after birth, it should be taken with a heel prick and should be done TSH. If TSH is elevated, then it has to be treated with iroxy. So this is up to a nutshell of a thyroid disorders as a whole. Next part, we will discuss about the subclinical hypothyroidism, which is the commonest occurrence and the commonest dilemma if we treat or don't treat these conditions when it is clinically euthyroid. We'll come to the later class with that. Till then, this is all from today, and we'll be very much taking another one with this subclinical hypothyroidism. Thank you.